Top Med Talk.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. We are coming to you with the coverage of the COVID crisis from the front lines. Now, we've had conversation with care providers all over the globe who are battling the virus and will continue to share their stories in hopes to provide education and support to the healthcare workers who are on the ground. Today, I'm joined by our editor-in-chief and recovered COVID patient, and now back to being a critical care doctor in London, Monty Mythen. Hello, Monty.
Hey, Desiree.
How are you feeling? If you've been following Top Med Talk, you know that Monty was a COVID patient for a couple weeks, but you are now doing pretty well, aren't you?
Yeah, I feel good today. Into work again for a short day, into one of our hospitals we managed to keep clean and have booted back up scheduled cancer surgery. So I was in there seeing the patients and liaising with my colleagues about how we ramp that up. And I bumped into some of my other more mature colleagues, us middle-aged bunch, the Peri-60 bunch, who were able to compare notes on how bad our COVID-19 had been.
Goodness.
So it's a relatively common gang to be in now. But we're back at work, so they've put us back. They don't know if we've got antibodies or not, but they've shoveled us back in there to get on with it.
Well, I guess if there's anybody to put in there, it's the ones who have the most experience and hopefully some antibodies. So,
well, sadly, I read some of the updates this morning about the likelihood that you have antibodies. The early reports are not suggestive that it's guaranteed. So I guess
we're going to find out.
keep donning and doffing until you get your own antibody results.
That's
I suggest.
That's right.
Yeah.
Well, our next guest comes to us from Philadelphia, Pennsylvania. He is an intensivist and critical care specialist at Jefferson Hospital there in Philly. We found out he actually has a background in biochemical engineering, which will play a part when we...
Biomedical engineering, I think he said.
Did I say biochemical?
You did.
Biomedical. I'm sure
he can do that. I'm sure he can do that too.
Probably so. He's very passionate about educating providers about the management of COVID patients. It's Dr. Herbert Patrick. Dr. Patrick, thank you so much for joining us on Top Med Talk. I know that you are extremely busy, so we really appreciate your time.
You're welcome, Desiree.
Can you give us a little bit of background about your hospital, where you work, and your role there at the hospital?
I'm a intensivist, a full-time intensivist. Our group of hospitals, number 3, and they have an ICU in each, even more than an ICU in one of them. And we round on every ICU patient in a, quote, closed ICU setting each day. We have watched the changes in our population in each of the 3 hospitals. Actually didn't expect the surge to occur in the one hospital that I'm at, and that has led us to 150% increase in ICU beds and ventilator usage.
About how many beds are total in the hospital there?
The total between the 3 hospitals are 600, and the total ICU beds are 70 at baseline before any takeover of other areas that we've turned into ICU beds now.
What other areas have you surged into?
At the one hospital only that has experienced the need to acquire, take over the extra beds, have been a move into what was a telemetry unit. It was physically adjacent to our ICU. Our ICU was also a step-down unit in that smaller hospital. So a 12-bed ICU expanded into a 10-bed tele unit to give us now a 22-bed complement, which is ready to surge, if necessary, into the PACU. We would then move into the PACU.
Dr. Patrick, have you been able to deploy critical care type of ventilators to all those bed spaces, or like many of us, are you making bridging situations, perfectly safe bridging situations, but adapting anesthesia machines and or transport vents? Or are you lucky enough to spec everything up?
We've been equipped with 12 high-tech, we have funny nicknames for them to make sure everybody knows. It's like labeling the ultrasound machines in the emergency room. You name and then you say, oh, go get Mary, I need Mary.
We've got Betty.
Yes, Mary. In this case, we have 12 high-tech vents, and as I mentioned, we do have that 12-bed ICU. We have rental vents and portable vents that are identical, that are handling the other patients. Once we get to the PACU, We do have what I'll call deployment vents that were purchased years ago during the flu and put in storage and have now come out, gotten dusted off. They would be our third to go to vent, however. We do run the high tech first to the necessary patients. We then run the portables, and we have not yet run the recalled from storage vents of the last pandemic.
What about your staffing? How has that worked out for you guys there?
The staffing is tougher than the equipment. Absolutely. We have a critical care pool. This was created over a year ago with no insight into how it might work so well. This can be moved between telemetry clinical applications and ICU applications. So they are not always in ICU, but they are trained to be. They are not always in telemetry, but they are trained to be. But we've then been able to make all of them ICU right now. That has expanded the necessary pool. To go on and train new ones, meaning new ICU nurses, let's take an area like the cath lab, which has reduced its volume heavily. We have the cath lab nurses in the ICU getting on-the-job training right now to become critical care competent. And they're supplementing our staff beautifully. And that's been our fallback for the staff shortage.
It's stressful for them, but everyone, from my experience, is stepping up to the mark, and they have the basic skill sets there. It's just adapting to the environment and being able to have that fluidity and speed that somebody who's doing it every day of the week does. But I mean, my experience is they're doing a fantastic job.
I agree. By working together, these nurses are not yet independent, and I hate to say, depending on the length of this pandemic and a surge, perhaps we hope they won't have the time to become completely comfortable. But this exposure is something they have stepped up to and have done a great job.
Dr. Patrick, can you tell us a little bit about the typical patient coming into you to the critical care unit, what they're looking like?
The patients all start out in the emergency room if they're from our community. So they'll come into the emergency room and be coughing, have a fever, and be short of breath. Whether a plain x-ray itself is satisfactory to see diffuse infiltrates, or whether the CAT scan gets done and we see the ground glass appearance, there's a very high suspicion that they are infected and do have COVID-19 disease. They then are triaged to either go to tele if their SpO2, if their saturation is satisfactory on nasal cannula, or mid-flow or high flow. Now, this invention of mid-flow is new, I think, for most of us, and it's really 4 liters of oxygen up to 15 liters per minute of oxygen. So if you're below 4, you're on plain vanilla nasal cannula. If you're on 4 to 15, you're on mid-flow. If you're 15 to 60, you're on high flow. So if a patient needs only nasal cannula or mid-flow, they're going to tele. But of course, I can say, as soon as they go to high flow, they are moved into the ICU arena.
You had any challenges, because we use a lot of high flow and a lot of CPAP, which we might come back to in a moment, whether people believe in it or not. I think we've become more aware of the oxygen flow capabilities of our institutions than we knew the dials were there somewhere, and we knew the specifications were somewhere, but we're sort of all over it now. We're very aware of our total flow, oxygen flow capabilities. Is that on your radar yet? Have you had to go there?
Yes, Monty. We can joke that if you look out the window at the liquid oxygen tank that's sitting out in the parking lot, we could see through the steel wall. With enough high flows running, we could watch that tank empty. We could watch that tank drop 60 liters a minute into a large number of patients, larger than we've ever had. Up to now has not led so far to an oxygen tank shortage from the major liquid tank outside the hospital. And it won't. Our deliveries have stepped up to keep that tank top off.
Before it was like water coming from taps. We turned it on and we knew it kept coming, and we'd sort of learned about there being upper limits, but we'd never flirted with it really. It's a tangible part of every day of the week now that we review our meters and our flows. Strange times.
Mm-hmm. I agree. That is correct. And teaching this normal flow, because I don't want to call it low flow, 0 to 4, but it is your lower flow. The mid flow is educationally baffling many of the nurses. What's mid flow? I mean, what is mid flow? And then high flow, of course, is better understood historically within our system. But the mid flow conserves oxygen, and if it helps the patient get their saturation, mid flow uses a slightly different nasal cannula than the high flow.
Yeah, that's what I was going to ask is the different devices. Are you still giving everything in a traditional nasal cannula until you have to go up to the high flow, or are you using oxygen masks or any other kind of oxymax max?
Desiree, it is done with the nasal cannula. So your just generic vanilla nasal cannula is your 0 to 4. Your mid-flow is advertised and provided if you buy the small humidifier with its nipple to go to the mid-flow cannula, which is not exactly a high flow and it's not as bulky as a high flow. And then, of course, the bigger system with the humidification that's heated, a heated system with a passover humidifier that takes you into high flow.
Sure. All right. You have your high flows, then stepping it up into critical care, and you see your patients escalating. What's it look like? So I kind of want to work through what we all know in healthcare is the ABCs, which we traditionally would be using in life support there, the basics, airway, breathing, circulation. So as far as airway goes, we've talked about flows of oxygen, but are you guys going into early CPAP to avoid intubation, or are you doing early intubation at your facility?
It is not early intubation. It is CPAP if you wish to recognize that sim CPAP exists with mid-flow and high flow. There really is a low-level CPAP. So we're not taking NIPPV units into use for the CPAP. We're using the mid-flow and high flow as a equipment saving ability to give the patients small levels of CPAP and high levels of FiO2 and flow.
In your unit there, because many people are avoiding the use of high flow nasal oxygen as well as CPAP because of the lack of negative pressure rooms. They're worried about the aerosolization and spreading the virus. Can you speak to that for your particular situation?
I completely understand that idea. There's no doubt that a patient with a respiratory virus generically is going to have an output of viral particles. What we do has revolved around using our negative pressure rooms, but our two rooms that are negative pressure in the ICU were used up 2 weeks ago and are always being rotated through. We have rented HEPA filter systems that are on wheels and bring them into the ICU room to create a HEPA filtering system. It is not negative pressure, but it is quite enormous. I have never seen this size HEPA filter with something like a 12-inch output and a 4 foot by 4 foot HEPA filter input.
Oh my God.
Hurricanes. But there's safety involved with this device inside the room.
Any critical care nurse or doctor knows where in the world do you put that thing? Those ICU rooms are tiny.
You put it in the place where you don't put the medical student.
Yes, but it also forms an excellent table.
Yeah, there you go.
Because if you're looking for a spot to put down your intubation supplies, you've got a giant table right next to the head of the bed.
Right now, that's filtering everything.
Is keeping everyone cool. Everyone is getting a breeze, a flapping gown breeze in this room. So we have moved to HEPA filters, and it looks like our insight into getting these filters rented ahead of time has provided us with HEPA filters in every room that we have a COVID positive patient or a COVID suspected person under investigation.
Well played. I mean, we get the impression, because we did a similar thing, that we've managed to keep a considerable number of people away from the need for intubation and ventilation. We never really know that until we get to analyze the numbers afterwards, but that's the sense we have at the moment, is there are these patients who are predominantly single organ, quite markedly hypoxemic, but a little bit of respiratory support, a little bit of positive pressure they seem to be getting through.
I agree, Monty. And the opportunity to do this is also with a patient who is awake, and we do ask them to lie on their stomach. We do ask them to prone themselves. By being able to prone yourself, we call that proning. Another question, it is proning. But if you ask me, do we prone typically our intubated patients, we do not have the resources or the equipment for that. We will do continuous lateral rotation therapy in our ICU beds, which is pretty good, 40 degrees right and 40 degrees left, not prone, but we will rotate the patients and look for the best position for their best SpO2, and have a patient on high flow, mid flow, CPAP, lay on their stomach and ask them, please, will you hang out on your stomach? You'll do better if you lay on your stomach.
Yeah.
You touched on the ventilation there, and there has been a lot of discussion about proning, and then, as you said, the practicalities of, well, it just becomes overwhelming to prone everybody until you have proning teams. Well done for having the tilting beds. Are you finding in most of the patients that the ventilation per se is relatively straightforward compared to a classical stiff lung ARDS, or is it phasic?
No, Monty, you're on to something. And why do I say on to something? If the listeners here, or if many clinicians won't accept that, they're behind the times. This is not ARDS. This is a viral pneumonitis that is acting just like a viral pneumonitis. There are not alveoli filled with water here. There are not alveoli filled with plasma here. I've bronchoscoped these patients to look at bronchoalveolar lavages. There is no alveolar filling, essentially. Therefore, the proning is not the proning of ARDS, and the treatments are not the ARDS exact treatments. I agree. Very, very good insight.
The trend, I think, that we're all seeing. And so when we were initially, everyone saying, this is ARDS-like, it's really, I think, some disinformation or we didn't know at the time. But so moving ahead, what are the type of ventilatory strategies that you're using? Because a lot of what's happening is that patients, once they get to the point and escalate to the point of intubation, it is just a deep dive off the edge. And then people are using high PEEP and treating it like ARDS. And then we're, into this whole hemodynamic catastrophe. So what type of ventilator settings are you doing to ensure that you're ventilating appropriately, but still maintaining trying to maintain oxygenation, I guess I should say.
No, Desiree, that's right. When I teach ventilator management, I start off by saying, is anyone here schizophrenic? Now, no one's going to put their hand up and say I'm schizophrenic. However, okay.
Maybe some days.
But the point is, you can't oxygenate and ventilate. You have to choose your goals. And if you think you can do both, you're going to fail at both. By picking oxygenation first, we have seen patients who have recovered from intubation due to what Monty mentioned as a single organ involvement. They are hypoxic, and they get my traditional and our American, I hope to say, traditional ventilator settings. So what is that? You're setting a tidal volume that will never exceed a plateau of 30 centimeters of water. Okay, now that's ARDS, but it's a guide, and we use that guide. Now, people will say, I always need the ideal body weight, and I have to multiply it by 6 mLs per kg, ideal body weight, and that's the number I'm putting on the vent. No, that's not the number we're putting on the vent. We're putting on a number that is causing the plateau to kind of kiss the 29 to 30 centimeters of water. Now, the PEEP with that setup is 8. It starts at 8. We're not going to 20. Well, someone might be going to 20. We're trying to stay away from 20. It has many, many disadvantages. So for the first vent settings, as a patient is intubated, they're intubated because they are hypoxic in the mid-flow or high flow. And now they need intubation for us to get a little more flow, actually. You know that the big tech ventilators can flow up to 150 liters per minute. 150. So if you just think of the vent as the highest flow, you got low flow, mid flow, high flow, and now you go to highest flow, you end up being able to oxygenate. So we let the vent do its own flow settings. We like a mode that is a hybrid between pressure and volume. It's pressure regulated, volume control. And therefore, with that volume set to give a plateau of more than 30, we let the flow set itself, and it often goes sky high in order to energize the lungs, recruit alveoli, and have us oxygenating the patient now.
Obviously, you've set your ceiling pressures, and therefore you've got the difference between the PEEP and your plateau pressure. I'm guessing you're ending up by default with breaths of about 8 mils per kilo.
Yes, we're likely by default 7 to 8. That's correct. And then the hypoxia is improving in the subset of patients we're talking about. And as the training house staff might be confused, because we've started out at 100% FiO2, and we've started out with 8 of PEEP, maybe we've gone to 10 of PEEP. The question is always, which do you reduce first as the patient oxygenates better? Well, the way I see it and where I was trained, you reduce the FiO2 and keep the PEEP on for recruitment purposes. And as soon as you're down to 50% FiO2, you've got a patient who's recovered, recovering. And you can start weaning them from the ventilator. And this is absolutely part of what's happening. We are not losing every patient who's going on mechanical ventilation.
No. On that is if they spiral, and we have a concern now that's moving around our networks about a downward spiral to multiple organ failure, that in part may be the application of ARDS type protocols to these patients that have a different disease. And part of that is discussions about fluid resuscitation, hypovolemia, dehydration, and the need for both, V and Q, ventilation and perfusion. So what approach have you taken on the volume resuscitation front?
Right. That's a perfect lead-in to the idea that with the ventilator and the schizophrenia, we're going into the second phase of the ventilator while we're looking at volume status. That second phase is sacrificing expiratory time, E time, and like Robin Hood, give it to I time. Give it to the poor.
That's exactly right. Yeah.
And so we take the E time and push it into I time. Well, at that point, we are likely to become hypercapnic. Yes, stealing the term from ARDS, we do recognize it can be called permissive hypercapnia. Okay, but that leads us into the volume status, because with the permissive hypercapnia patients, I am now 100% of them concerned with their volume status. So I'm admitting that if I am rescuing the patient and pulling them down from 100% FiO2, 8 of PEEP, to 50% and 8 of PEEP, life is good. If I am using permissive hypercapnia, we are adding a volume determination immediately. To me, we need that volume status. We're doing that with dynamic devices that do give stroke volume index and cardiac index to these patients. And if we see a low stroke volume index, they have got to get fluids, or we're going to get into cardiac output trouble and the potential cardio-renal type syndrome as multi-organ failure occurs from misdiagnosed hypovolemia.
To walk it back just a few steps, is that whenever you first intubate somebody, reports of just them crashing and burning as soon as their intubation, probably related to the hypovolemia that they've come into the situation for, as among other things. And then as soon as you get them intubated, people are wanting to still run them dry. Are you actually putting the monitoring technology on that you can determine that what their actual volemic status is whenever you first intubate before they actually may start spiraling and you have to change vent settings?
Well, yes, I wish we could. And this is a limitation of how many cardiac output electronic devices we have. If I have 22 beds, I don't have 22 computers. Gotcha. Although I can say from several companies in the United States, we have been offered free for use during this pandemic, those equipment that will give us the stroke volume index, which is your intravascular volume, and your cardiac output. So we have not had the crash and burns with these intubated patients. Now, either it's because we've moved from high flow into this intubated status and we're simultaneously watching for the hypovolemic patient. I will not tolerate hypovolemia. We're only going to have this all backfire if we keep the patients too dry.
Yeah.
And on that point, have you seen much need for hemodialysis yet, for renal support? There's always going to be some in any sick patients, but have you seen a lot or not too much so far?
Well, again, Monty, you're right on and you're a step ahead of other clinicians. The renal teams we're working with are astonished. Now, everyone is going to say, I've never seen anything like this. I mean, all I hear all day long is, I've never seen anything like this. But what the renal teams are saying, I respect. They've never seen anything like this, which is the climb of creatinine at a trajectory that is inconsistent with a cardiorenal syndrome. This is a climb that is pushing us into almost round-the-clock use of the dialysis nurses to handle these patients, not because they're wet, but because they're encephalopathic, their BUNs are very, very high, and because the creatinine trajectory has gone from 1 on Monday to 3 on Tuesday to 9 on Wednesday. This is astonishing. And so the renal team has stepped up to help these patients. It's not for ultrafiltration. It is helping the bicarb losses that the acid pool is pushing into the blood. And these patients have bicarbs that might be 14, 12. Well, now you're talking hypercapnia with bicarb of 12. Well, your pH is 6.9. This doesn't work. So renal has been so supportive in running extra dialysis sessions with a high bicarb bath to get our patients, or attempt to get our patients up to a better bicarb.
I get the impression you're hypothesizing it's a form of metabolic correction and electrolyte correction they're helping with rather than a pre-renal failure type of picture. It's the whole sort of the soup of whatever the virus is doing, the hyperinflammatory states, the muscle breakdown, the red cell destruction, the hepatic abnormalities, creating this milieu which is unfavorable for cellular function.
You said it better than me. That is correct. Correct. And if we take the hemodynamics to the next step, which perhaps you're ready to ask, this invasion is also occurring in the heart in patients. To lose cardiac output as quickly as we're losing it, these computers are on and telling us the patients are not hypovolemic. We are getting a cardiogenic shock on top of everything else that's going on. And there's literature that supports that viral myocarditis can be a factor. And so, as you say, add this up. We have hypoxia, we have cardiomyopathy, and we have renal failure metabolically. It keeps us busy.
And Dr. Patrick, echo, for example, do you see a sort of biventricular stunning rather than a lot of pulmonary hypertension and right-sided failure?
Yes, it is.
Was it mixed?
Stunning that I wish I could call the famous myocardial depressant factor. love to call it that, but it's not the one we're used to. It's not that factor. This is much more virulent, much more fast. And by taking out the cardiac output, we know these patients are now spiraling down. When we're permissive hypercapnia, we're losing cardiac output, and we got a bicarb of 14. No, that's it.
So everything possible not to get to that state. But sadly, we can't win every battle, but we've got to try and keep as many people away from the edge of that cliff as possible.
That's correct, but it is a viral-driven pathway. I was so personally affected by our first death because all of the things we've talked about were a repertoire that a thorough intensivist knows and should bring to the bedside and bring to the ICU team. It's like the huddle and break, and we're going to the bedside, and we can make this happen. And then the heart goes out. This is devastating to the clinical team to watch the sudden death that occurs. Together with the VTACs and the SVTs that these hearts are going through without any prediction, but it fits the myocarditis that we suspect is present.
Well, thank you for sharing that harrowing story. Desiree, I know you wanted to, because we're up against time now, to touch on some educational support materials, because it's a wonderful conversation that we're dominating between the two old men here. But
I'm sitting, I'm just thinking about all of it. I mean, I'm just, I'm trying to, just process it all and think about the difference in care. I mean, I'm just comparing the difference in care, that has been what traditionally has been ingrained in all of us critical care providers, and how this is, I can't imagine the challenge on the ground and how it is impacting everyone. So thank you, Dr. Patrick, for going through all of that. So you're a biomedical engineer, right?
That's right. I trained in electrical engineering at the University of Pennsylvania, and found myself entering the biomedical field at a time where the word biomedical, like intensive care, was not really in the vocabulary.
I think it seems like from our conversation, it puts you in a unique perspective to become an educator. And we were talking about upskilling some of your, different types of providers and bringing them in. And it seems like something that you're very passionate about. Can you talk to us about your experience with trying to upskill and taking some of the principles and background that you have there in engineering and applying it to what we're doing for practitioners on the ground right now?
Well, yes, this becomes a train the trainer. We only recently had a position offered and filled immediately for a nurse ICU educator. Now, you'd have to first think, how can you even run an ICU without a nurse educator? But small hospitals do all around the country. So many may be listening and have no nurse educator. Perhaps this pandemic might change that, because that nurse educator for us now is at the bedside, sleeves rolled up, doing a fantastic job in helping nurses set up equipment that they're not comfortable with typically, and educating them on the spot. To me, no better education environment occurs than when you do it at the bedside on the spot with that patient. So we have taken the efforts to train the nurse educators, and they now are crisscrossing between our extra beds, helping the pool nurses, helping even the ICU nurses who are not comfortable with stroke volume index, who are not comfortable with the cardiac output device. And so our first big step was train the nurse educators to go out and care for more training. Our nurse educator is just fantastic. Her name is Joanna DiLeonardo. Joanna goes ahead and makes up the most attractive handouts that are brief but powerful. She doesn't overdo a giant, it's not in a binder that's 3 inches thick and you never want to open it because you don't even believe you have the time. They are concise. The little humor added to it is perfect. And I told her that she should be publishing these, that these are actually so valuable, and her insight as a nurse. And she used to be a clerk. She was a clerk in our ICU, and she went to nursing school. So once again, is education done better by people who watched what was going on and had no idea till they went to school, like a nurse or my physician training? Does that make us better educators? Well, at least for Joanna, I'll say yes.
Yeah.
We'd love to talk to her.
We would. Yeah, that would be fantastic. You guys really should publish that. I've had so many people tell me we don't have time for education. We can't do this, the hemodynamics, we don't feel like we have enough time to on the ground educate. And I'm just like, you don't have time not to do it. And if you can make it concise enough and put it in something that is very succinct and just like you said, what you guys are doing with Joanna, that's what we need. I mean, there are so many providers out there who are kind of just wading into this wilderness of, I think I've, kind of have an idea of what's going on, but this is so different. That's what we need. It's a great point, Dr. Patrick.
Right. The other part is call it an easel, but it's a paper easel. It's the Scott, a 3M company that puts together a 3-foot by 4-foot paper easel where when you peel it off, it's sticky at the top. So you stick it up on the wall outside the patient's room. And it's after you've written on it with your water pens, and you put down the ideas of mid-flow, high flow, P, plateau pressure not to exceed 30. You put these onto this, stick it to the wall, instant education.
That's true. Do you put parameters for where you're kind of trying to keep their hemodynamic parameters?
Yes, we do. And now to say we use the paper for education and we use the window to write those parameters because those parameters can change, but we hope our education is a foundation that's basic and we actually keep those sheets of paper. We keep the sheets. We call it ICU Teach, and that's at the top of the paper, and then the contents describe the topic right there on that sheet of paper.
It's going to be great to be able to go back and look at those.
That's right.
You're right on the windows. You've got to lock up the wrong markers. Otherwise, you're in there at the weekends with a razor blade trying to fix it.
That's correct.
Get those reading glasses on and check closely. Ask one of the youngsters, say, what does that say? Does that say permanent? Or That's been brilliant. We know we should let you go. You got work to do, my friend.
Yes. Thank you so much. Thank you so much, Dr. Patrick. You are doing amazing work there. Would love to talk to you again and perhaps Joanne about your experiences on the ground. And again, just thank you for everything that you're doing to care for these patients. It's good to know that there are people out there forward thinking like that. So
this is exciting to know I've influenced more than my little posse.
Your corner of the world there in Philly. Well, good luck to you on everything, and we'll talk to you soon. Okay. And just to wrap it up here, to everyone at home, or if you're on your way to work or wherever you are, we're going to get through this. We're here for you on Top Med Talk. So stay safe, stay well, and thank you so much for listening.
Top Med Talk. Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.